As 36,000 nurses confirm their plans to strike this month, we begin this morning with a stark warning from two prominent doctors who say healthcare in New Zealand has been commodified and that we're fast headed towards a US-style healthcare system. Dr. Phil Bagshaw is a general surgeon and the founder of the Canterbury Charity Hospital, and Dame Sue Bagshaw is a primary care specialist focused on adolescent health. Kia ora kōrua. Thanks for being here.
Kia ora.
Phil, let's speak in general terms first of all. What are your concerns?
Well, we're concerned that the Minister of Health wants to offer 10-year contracts to farm out non-urgent surgical care into the private sector, and we think that's a very retrograde step.
Why?
Well, there are a whole load of reasons, but it will mean there'll be less money for the public sector. It means that the doctors will gravitate into the private sector. There will be no teaching or training. For lots and lots of reasons, it will mean the public sector will go down as the private sector goes up.
So by using private hospitals to perform electives, I think some 21,000 additional surgeries are scheduled to be performed in addition to what was previously planned. So if private hospitals can reduce the backlog of elective surgeries and get people seen faster, what's the problem?
Short term's fine. Long term, definitely a big problem. Most of the training happens in the public sector. Most private patients don't want to be trained on, if you like. And that's the issue. So long term, we will see doctors leave the public system. They won't be well trained because they haven't got enough practice. And long term, it just will basically become a private system where if you can't afford to pay your insurance, you don't get health care.
So in his letter of expectations to the Commissioner, the Health Minister talked about prioritising 3-year contracts with private providers, but said that 10-year contracts should also be considered. In your view, when you're thinking about short-term versus long-term, what's the difference between a 3-year and a 10-year contract? 10
years is quite a long time. 10 years is 3 politicians' journeys, if you like, and that's a long time. So I think we really have to be much more focused on the future.
Phil, are private providers more efficient than the public sector?
No.
Why not?
Well, they're doing a very selected group of patients. These are not urgent patients, they're not complicated. They're turning the handle on hernias and veins and things like that, which are relatively simple and with low complication rates and not requiring the degree of sophistication that you need to be present in a composite healthcare system.
But obviously by doing that work, they're taking that workload away from the public sector, so the public sector can perhaps focus on those more complex cases.
But they will take the money away as well.
But
the
also,
money will go with those cases.
There's only a finite number of doctors and nurses. So if they're spread across 2 places, there won't be enough in the public hospital if they're all put into the private hospital to clear the backlog. What are we going to do with the complicated urgent people?
And training. We have to train our doctors and nurses in New Zealand. We cannot afford to buy them. The public system does all the training and there will be none. The private system is not concerned about training doctors and nurses or anything else. The public system trains them all and then they gravitate out into the private sector where the environment is more friendly.
Can you talk to us a bit more about that as well, Sue? What are your concerns with regards to the health workforce?
My concern is that in terms of surgery, you not only have to learn the complicated, difficult things, and that's obviously important, but you don't get there in one big bold step. You have to do the little, smaller things first to train you to deal with then the bigger things where it can go wrong. And the problem is, if you're only trained in private, because that's where the patients are, you won't be able to do the complicated things. And if you're not trained on the complicated things, what's going to happen to you if things go wrong in the private sector? You go to the public hospital, sorry, we haven't got enough doctors.
So, Phil, you say that, that this is one area of concern when it comes to government policy in the health sector at the moment. You've also raised concern about the use of PPPs. But how do these steps ultimately lead us to a US-style healthcare system?
Well, it becomes more and more focused on a sort of neoliberal philosophy where hospitals are there to make money and we purchase health. That's the notion. It's a commodity. Now, health is not a commodity. Health is a common good. And unless we focus on fulfilling the common good, then what happens is we end up solely focused on the money. And that's what an American system does.
You say that this trend has been in place since the late 1980s. How so?
The trend started with Rogernomics. That was the first hit. And then the really big hit was 1990, when we had the mother of all budgets. Both of those really started to take all the resources out of health. And progressively since then, the public system has been getting less and less resources.
But is the public system efficient when it comes to using the resources? I mean, I look at the spending over the last few years. In 2018, 2019, pre-COVID, the annual health funding was about $18 billion. This year's budget, health was allocated $32 billion. So healthcare costs have increased faster than inflation, but there are massive staffing issues, still significant delays in the public sector.
Well, firstly, don't believe any of those figures. You can go to government sites and get completely different sets of figures.
I'm just going from those are the figures allocated in the budgets for those years.
Okay, well, but anyway, we have to think of a different way of approaching this, and we need to be moving to a better model. And probably one of the best models is the social insurance or the social democratic models that are there in Europe and Scandinavia.
How do they work?
Well, the Scandinavian one is all about taxation. People are taxed, they expect to be taxed, but then they get free health and education. The German one, that's all about insurance. So the companies pay the insurance and so do the individuals. But every citizen has a right to care. Whereas now in New Zealand, no, every citizen doesn't have a right to care. The two systems, the public and the private, are moving apart, and patients are falling through the gap between the two. And the charity hospitals are there to try and do something about that expanding gap.
I'm going to ask you about the charity hospital and what you've observed through your work with the charity hospital in a couple of minutes. Sue, you were going to say something?
Well, when you live in a country where a quarter of the population can't access a GP, that's something to worry about. And when you live in a country where many general practices are now being run by commercial companies, that's something to worry about, because they're there to help their stakeholders. They're there to pay their share holders.
But again, it comes down to a question of efficiency, and I go back to those numbers.
When you have managers in charge who don't know about how to deliver health, all they care about is how much it costs, you're going to get inefficiencies.
Right, and so
it's guaranteed.
Are you suggesting that the health services and an increasing bureaucracy in public health services are to blame for that massive expansion spending and a reduction in services? Absolutely.
The private sector is run by doctors and nurses, and they say when they can do the operation and what operation they're going to do. Not in the public system.
So the private sector is more efficient?
Only because it does very small cases with least complications and least complexity, if you like.
And the public system is there to pick up the problems as they arise.
So a decade ago, 98% of patients waited less than 4 months for elective surgery in the public system.
Did not.
The waiting list figures are an absolute nonsense.
Today it's 57%, according to those numbers.
Now they're counting them before they didn't.
Right. You dispute those figures?
Oh, yeah. At one time, there was a very simple system in New Zealand. Your GP thought you needed to be seen in a hospital. Your specialist in the hospital thought you needed an operation. You got your name written on a list and have an operation. Now, you go to your GP will go to the computer, and the computer will say, no, we're not doing that right now.
So, Phil, for anyone who isn't familiar with the Canterbury Charity Hospital, you use philanthropic funding to try and fill that gap, to provide services that aren't met by either the public system or the private system. What has your experience with the charity hospital taught you about the current health system and how it might or might not be working?
Well, the unmet need for healthcare is massive. That's what I've learned. And it runs across the whole of health. At the charity hospital, we have a whole raft of different services: surgical, dental, endoscopy, all sorts of things that are just not provided for people. And these are not trivial things. For example, we now do the endoscopies for people under 50 with rectal bleeding for the whole of Canterbury, because otherwise it would not be done.
Would a charity hospital be necessary if the public healthcare system was working?
Well, I would have the biggest hope in the world that one day we can put a sign on the door that says not needed anymore. I think the likelihood of that happening is so small, I've forgotten about it.
Unless we have a big change in our political ideology.
So talk about this alternative vision a little bit more. You look to a Scandinavian or a European style system that would inevitably mean more costs for the healthcare system, right?
Look, there will have to be a big input of money.
Right.
But the issue here is all of the serious research in Europe, which is massive, shows that as soon as you start putting money into elective healthcare, you start saving money hand over fist. There are things called fiscal multipliers, which basically means that you treat people early, you reduce the complication rates, you get your young people going back into work quicker, you get your elderly people being independent longer, and for all of these reasons, both health and education should have big inputs in money to produce the big savings that we're not getting here in this country anymore.
The trouble is the savings happen long term, not short term.
Right.
If it's not within the impetus of this government, why bother about it?
The forecasting period. Yeah. So if it requires a huge financial input, and I've described the financial input of just over the last few years that perhaps hasn't been met by an increase in services. Where does the money come from?
It has to come from the people. But, 1% of the New Zealand public own the country. I mean, the billions of dollars. It's really interesting. Money is one of the few things in the world which defies the laws of gravity. It floats up. Under the neoliberal system, all the money that you're talking about has been floating up to the top. And the bottom 25% haven't really got enough money to live on.
So you're talking about more borrowing, or are you talking about higher taxation, or are you talking about a combination?
Higher taxation and, I would like to see a big wealth tax, personally. The problem with wealth tax is the very wealthy hide all their resources.
Do you think there is an appetite in the New Zealand public for what would be quite a radical shift when it comes to tax and redistribution in order to fulfil what you see as a better healthcare system?
I think if they felt their taxes went into health and nowhere else, I think they will be more. There was a survey done not that long ago saying, would you be prepared to pay more taxes in order to have better health system and education system? The vast majority said yes, so long as they know where it's going. At the moment, we pay our taxes, we have no idea where it goes.
What kind of support have you had within the medical fraternity for your alternative vision?
Well, it varies a great deal. One of the problems is some of the major organisations in health are not speaking out adequately enough.
Right.
The colleges should be speaking out about this issue, and the unions should. The unions have done some, but they should be getting together and they should be saying that what is planned here long term is not in the long-term interests of the New Zealand public, and explaining what is a difficult situation. It's hard to understand, but if people understood just how bad it's going, they would appreciate the need for radical change.
I think doctors and nurses are fed up with not being allowed to do what they're trained to do. And that's what's happening in our hospitals right now. That's why 36,000 nurses are going on strike. They're fed up with going into work, being stressed the whole time because there's not enough nurses to look after the patients, not being allowed to do their job that they're trained for. That is a disastrous combination. It's not money that's needed. Well, money's obviously needed, but at the same time, it's a change in attitude. It's a change in ideology, so that nurses and doctors are allowed to do their job, and managers are there just to help them to do their job.
Dame Sue Bagshaw, Dr. Phil Bagshaw, thank you very much for your time.